20-year-old girl, young lady with recurrent pancreatitis. She had undergone an endotherapy in the past. This was about a few years back. Now she came with some symptom. Now let me tell you, for those who are not familiar with the demographics of pancreatic disease in this country, we see almost every day at least 2 to 3 new patients of recurrent acute pancreatitis or early chronic pancreatitis or even established chronic pancreatitis. So what I'm going to do now, for any patient with pancreatic disease, the most important investigation for the patient is endoscopic ultrasound. Because what it will allow, pancreatic evaluation on EUS allows me the parenchymal evaluation, the ductal evaluation, if there is a mass in the setting of chronic pancreatitis. So those who are starting career in EUS, always go to the second part of the duodenum, lock yourself there, start your screening from the second part of the duodenum, and I'm going to go change my frequency to 7.5 megahertz. I'm slowly withdrawing the scope. I'm going to go straight on the pancreas. What is pancreas doing here? So let's have evaluation. I'm looking at the bile duct possibly. This is the CBD. You can see the gallbladder here. So in a matter of few seconds, once you are in the duodenum, in this particular position, you'll see beautiful cross-section of the bile duct. And why I would say it's a bile duct? Let us have a color Doppler signal. Look and see that. So what is not lighting up, you can see here, what is not lighting up is the bile duct. Rest of all the vessels around, this is the portal vein, this is the pancreatic head. That's the gallbladder. So we saw the bile duct here. Now I want to see the pancreas. That is important. We are seeing the pancreatic head, and I am seeing something in the pancreatic duct. Oh my goodness. Look at that. There are some filling defects in the pancreatic duct. Now what I'm going to do, for those untrained eyes, it might be very, very difficult to identify. So I'm going to go and magnify the picture. Magnify the picture, and I can actually see some filling defects floating in the pancreatic duct. Look at this. This is a dilated pancreatic duct. How much dilated? Let me find out. Pancreatic duct is dilated, almost 9 millimeter duct with filling defects. You can see some filling defects. So these are soft sludge ball or soft stone in the dilated pancreatic duct, just in the head of the pancreas. So I'm completely convinced this is the cause of our recent symptoms, and therefore we can consider removing. Now I'm sure people may argue, why not an IPMN, main duct IPMN? Well, we know the history of this patient. Patient has recurrent pancreatitis in the past. She was undergone chronic pancreatitis endotherapy. You can see the dilated duct. Now you'll argue, why would you say this is a pancreatic duct? Again, I'm putting a color Doppler signal, and you can see that the pancreatic duct is not lighting up at all. And you can see these are the side branches of the pancreatic duct. So I'm completely convinced we are dealing with chronic pancreatitis with soft stone in the pancreatic duct in the head region. And when I'll do the endotherapy, because that's what I'm planning to do now, because I've seen this patient is suffering. She will not settle down till the muck is out, let me tell you. So this is the pancreatic duct you can see here. And now I'm going to see the gallbladder. So gallbladder looks fine. Patient is fasting because she has an acute on chronic pancreatitis. So this is the gallbladder. Very quickly we'll move on to the body of the pancreas. Let me see if there is any pseudocyst or any changes of calcification in the pancreatic parenchyma. So I'm seeing the pancreatic body from the stomach, and I'm seeing a dilated pancreatic duct there. So now I'm going to show you what is the dilated pancreatic duct. Okay, let's do it. You can see this is the pancreatic duct here. So I'm seeing the pancreatic parenchyma here. This is the pancreatic duct not lighting up. You can see that, and this is the pancreatic parenchyma in the body of the pancreas. I'm chasing the pancreatic duct in real time. On color Doppler you can see that very gently, and I can see some atrophy of the gland in the tail of the pancreas, because this is the splenic vessel going into the splenic hilum. So you have to imagine as if you're watching a CT scan plate from the foot end of the patient, and you can see the splenic vessels going in the splenic hilum there. So you know this is the tail of the pancreas area. This is the part of the tail of pancreas here. So I can see some atrophy of the gland. For those who are not seeing chronic pancreatitis routinely on EUS in the Western world, especially non-alcoholic disease, because these patients are non-alcoholic. EUS biliopancreatography. Well, I just showed you a beautiful bile duct. I'm showing you a beautiful pancreatic duct in real time. I'm chasing the whole pancreatic duct. You can see the celiac artery taking off, bifurcating into splenic and the hepatic. Here you can see this is the aorta. This is the celiac takeoff. This is the splenic artery. This is the hepatic artery. And this is the pancreatic duct. This is the body of the pancreas. So we are very much convinced that what we are dealing with is the chronic pancreatitis. I'll put the color Doppler signal for your kind information to see the vascular structures in a proper perspective. So you can see how the celiac artery is taking off. The splenic and the hepatic are bifurcating. You can see beautifully the pancreatic duct not lighting up. And this is the kind of anatomy we can see on EUS. And therefore, ladies and gentlemen, there is absolutely no doubt in my mind, if you want to see pancreas in detail, disease related to pancreas, I feel EUS perhaps at present is the best imaging modality for pancreas. And therefore, I'm convinced there is no pseudosis. There is acute on chronic pancreatitis. Her amylase and lipase levels are high. So, a fundamental question, why would you touch this patient in acute pancreatitis? Let me tell you, if I don't treat this girl, she may have a florid attack of pancreatitis. And therefore, I'm going to go in now, and I'm going to try and clear the duct right now. So that's what we do. So again, I've been propagating EUS ERCP interface across the planet for the last 15 years. And I'm convinced beyond doubt that both these imaging modalities, EUS and ERCP, they both go hand in hand. It cannot be in isolation. Just hold on for a moment. Okay. Ladies and gentlemen, I'm going to try and cover as much as we can today because our patients are also waiting for the procedure, as you can see here. So I'm coming back to the fundamental question here. If anybody is suspecting pancreatic pathology, at least in our experience, I have missed so far in about 17,000 EUS, that's what I know, about a couple of patients where there was an isoechoic pancreatic tumor, which became hypoechoic later on. So there is, Manu Bhutani has presented his data many, many years ago regarding missing out on pancreatic lesion even on EUS. So EUS also has some shortcomings, but if EUS is saying there is no tumor, by and large, I don't think there will be any problem with the pancreas in that case, in 98 to 99% of patients. So in other words, EUS, as our experience have shown, is probably at present highest negative predictive value for pancreatic SOL or a definitive disease in pancreas. EUS is, somebody has asked me a question, how is EUS better than CT scan or MRI? Now the advantage of EUS, you have to understand that it's a real-time evaluation, number one. The ultrasound technology or the ultrasound property will allow you to diagnose a tumor from a stone much better on an ultrasound rather than a small tumor to be picked up on a CT or an MRCP. Therefore, the spatial resolution, the contrast resolution, though may be comparable with CT and MR and EUS, but the scanning proximity of the gland is much better with EUS. You can switch over frequency. We can switch over from 6 megahertz, 5 megahertz, all the way to 15 megahertz or 20 megahertz, and you can have a detailed evaluation of the pancreas. So now I'm using, but therefore, see, doctor, it's a very, very important question that why you would do EUS in all the patients of suspected pancreatic disease. And the answer is very simple. because CT scan is a more of a panoramic evaluation. It is not a specific focal evaluation, while endoscopic ultrasound is right sitting on the duodenum, in the duodenum. You can see this ulcinate process, you can see the pancreatic head, and you can have an excellent evaluation. So now what I'm going to do is, there is a little difference in our approach. As I said, we deal with a recurrent acute pancreatitis or chronic pancreatitis almost every day, at least few patients every day for EUS and endotherapy. So our approach, and I'm talking to my colleagues in the West, because they have a different school of ERCP where they will always inject contrast and go ahead. Now I already had a pancreatogram on EUS. I don't need a pancreatogram, so I will go straight with a wire. I'll go straight with the guide wire into the pancreatic ducts. Look at that, what we do. We have a different technique here, and I'm sure more and more centers, when they start doing a lot of pancreatic work on, okay, now I want the patient to be on the supine position. I've already picked up sludge and some muck in the pancreatic duct, as you must have seen earlier. You can see on fluoroscopy, the wire has gone inside the pancreatic duct, and I'm climbing up in the pancreatic duct. Look at that. We will take out the guide wire at this point. Okay, we have gone in, and there could be a stricture at the junction of the body and the tail, dilated pancreatic duct and filling defect in the head. Ladies and gentlemen, I want you to focus on the pancreatogram now. My duct is, my cannula is in the pancreatic duct. You can see that. Inject contrast. Gently inject contrast. Yes, you can see the dilated pancreatic duct filling up beautifully, beautifully. And you can see some filling defects. Freeze. You can see some muck coming out of the ampulla. Look at this. All the protein plugs which you saw. Can we have endoscopy view? Can we have endoscopy view? You can see all the muck coming out. This is what I meant by soft stones. Our population in India, where you see young patients with recurrent pancreatitis, and when your doctor says that nothing can be done for pancreatic disease, I don't think they are right. They have to do endoscopic ultrasound and do proper job for these patients. So what I'm going to do now, I'm going to leave a guide wire. Let's leave a guide wire into the duct. Yes, push the wire. Let me go up. Let me go up. Yes, go up to the tail if you can. We will go up to the tail if we can. Yes, we'll take. Now, whenever, for those who are starting endotherapy career for chronic pancreatitis, I have a small tip for them. You need to have hydrophilic guide wires in your armamentarium, otherwise you can forget about doing a pancreatic endotherapy, especially when very difficult cases you encounter. So I think we are very lucky to have an interesting case today in our hand, where this girl came with severe pain, and now my assistant is going to push the wire right up to the tail of the pancreas. You can see the conventional guide wires could not go, but we'll try and go up to the tail of the pancreas so that at least we position our guide wire well. Yes, now he has gone in. Look at that. So this is how we try and go up to the tail of the pancreas. Now here, I've gone in the tail of the pancreas. Very good. He's going to take out the guide wire. So in a matter of 1 minute, we were able to negotiate right up to the tail of the pancreas. And then we will leave a stiff guide wire. And I'm going to do one thing, is something called the balloon sphincteroplasty here. There was a history of a pancreatic sphincterotomy, you can see here. But I'm going to leave. So there's one guide wire. Obviously, there is some narrowing in the prepapillary region. Therefore, she has developed stasis for a while. And therefore, she has developed stones, soft stones, leading to pancreatitis. So, ladies and gentlemen, it is very important to identify which patients of acute pancreatitis. Yes. There are two questions for me. One from Canada, I suppose, one from Pune. And I want to address to both of them. Why do you turn the patient on supine? if you want to do very good quality pancreatic endotherapy, especially when you are looking at very, very subtle ductal changes or some ductal anomaly where you are not very easily going to enter, say for S-shaped duct or an alpha loop of pancreatic duct, we feel that supine position gives you the excellent real-time anatomical correlation. And therefore, I prefer, another important thing is that when your patient is in prone position, I personally reckon that because of the air in the stomach and the duodenum or in the bowel, patient sometimes gets little more uncomfortable than on the supine. Of course, there is a risk of aspiration, so we always make sure that we suck out the stomach completely dry before we go into the duodenum. So this is a very important question, Dr. Gupta. Now coming to Dr. Mandar's question, yes, you can diagnose. In fact, we were the first one, perhaps one of the first few ones in the world in 1999. We presented our data in DDW where we showed 89% accuracy of picking up a pancreas divisum on EUS. So here, as we can see here, we are doing balloon sphincteroplasty. I'm using a 6 millimeter balloon, and we are dilating the prepapillary narrowing, as you can see here. My assistant is going to keep a tab. And what we're going to do now, fluoro please, yes, very good. What I'm going to do is I'm going to sweep this duct with a balloon catheter, a stone extraction balloon catheter. Patient has a little pain. Go slow a little bit. Yeah, we have already gone up to the maximum diameter. And that's why patient has some pain. We'll hold it for there. So, Dr. Mandar, yes, you can diagnose pancreas divisum, but the key to is you have to chase the whole pancreatic duct in real time. You have to chase the duct in the duodenum from the genu or beyond. If you can see the duct in the body as well from the duodenal bulb. So you can see the duct, then you chase the duct in real time. Make sure that this duct joins the bile duct at the ampulla. This almost rules out a complete pancreas divisum. If for some reason you're chasing the duct and this duct opens up directly on the duodenal wall without meeting the bile duct, then you have to suspect very strongly a pancreas divisum, and you will see a very short stack sign in the pancreatic prepapillary portion where the bile duct will be full, but the pancreatic duct will be hardly 1.5 centimeters or so, and then it dips into the uncinate process. So if it's a complete divisum, you will have this kind of absence or a very short stack sign. Deflate the balloon. Fluoro, please. So now I'm deflating the balloon. Excellent question. Why a balloon sphincteroplasty? Now this patient has undergone a sphincterotomy in the past. So again, a very important lesson for those who are going to do revision ERCP. If somebody has done an ERCP in the past, you don't know how much needs to be cut. If you're not sure that how much is the intraduodenal portion of the pancreatic duct or the bile duct, I would prefer a balloon sphincteroplasty if there is already a sphincterotomy in the past done. And that's what you can see here, that there is a sphincterotomy, pancreatic sphincterotomy, and we have done balloon dilatation. So there is some prepapillary narrowing in the head region. So therefore, we have not extended the pancreatic sphincterotomy. Had it be a biliary one, yes, I would have extended without any hesitation. But whenever we talk of pancreas, I go a little slow, especially it's not a calcific chronic pancreatitis. Which stones would you send? Now, I will send a patient for ESWL, Dr. Gupta, straight away. If a patient has large stone, radio-opaque stones, impacted behind the ampulla in the pancreatic duct, either minor papilla or the major papilla, and this patient will go for ESWL first. After the 2-3 sittings of ESWL, we'll compare whether the stone pulverization has occurred, and after that, we will go ahead and clear the pancreatic duct once we are sure. Now I'm putting a stone extraction balloon catheter. I will go right up to the tail of the pancreas, you can see on fluoroscopy. Fluoro, please. Yes, push the wire. You can see all the muck coming out. Oh, la 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 la. Look at that. This is what I meant. Soft stones. Ladies and gentlemen, these are the soft stones which causes pancreatitis in our young patients in India. Look at that. Look at that, all the putty-like material. So what I'm going to do is, I'm going to go ahead and sweep the duct one more time. And then I'm going to leave, for your kind information, I'm going to leave here 2 7-French stents. 2 7-French stents. The reason is, there is a possibility of some muck in the side branches. So if you are putting only one stent, the stent may pass out because of sphincteroplasty. You can see that. Wow, look at that. I've cleared the duct completely. So now, what I'm going to do is, I think this... role of pancreatic jejunostomy or surgery. Now, I'm asked this question by a leading gastroenterologist of India, who is online just now. Dr. Vaibhav, I would suggest that there is still role of surgery in chronic pancreatitis. However, you have to select which patient qualifies for surgery. Flora, please. So, for last 15 years, we have very clear protocol. Any patient who has recurrent acute pancreatitis or chronic pancreatitis established will go for an EUS mapping of pancreas. Once we have EUS mapping of pancreas, we will be in a position to identify whether this patient has a pancreatic head mass, inflammatory, or pancreatic calcification in the parenchyma, or it is purely ductal disease, whether there are stones in the duct and nothing in the parenchyma. Now, if you don't have any disease in the parenchyma, these are the patients who qualify for an endotherapy without any debate, including large stones, because large stones can be pulverized with ESWL. Now, coming to your question, when do you need surgery? Yes, patient has extensive parenchymal calcification. Now, for technical reasons, those who are online, I'm putting a 10 French homemade biliary dilator. Look at that. This is a Teflon biliary dilator. Fluoroscopy, please. I'm pushing it on the guide wire. Look at that. I'm pushing it on a guide wire. Why did I do that? One, I have already dilated with a 10 French. Now I'm going to put a wire through this, so I do not create any false track in the pancreatic duct stricture area. So this will add to more injury to the ductal epithelium. And therefore, it's our experience of over hundreds and hundreds of patients with chronic pancreatitis. Fluoro, please. Yes, my assistant has put his next guide wire. So the fluoroscopy. I want fluoroscopy picture. Both the wires, and now he's pushing both the guide wires. And you can see that I'm bringing out infective pancreatic necrosis, role of EUS. I don't think there is a role of infective pancreatic necrosis, except if you want to do EUS guided endoscopic necrosectomy. Diagnosing pancreatic necrosis on EUS, yes, it is possible. You can see air, like what you see air on a CT scan. If there are gas-forming organisms in the necrotic material, yes, you will be able to see air even on EUS. There is no problem. But that is not the ideal indication for just give me a moment. I'm preparing my stents now. And I'm going to prepare our stents in such a way just give me a moment. Let me have the knife, please. So a lot of studies have shown that you should not have side holes, you should not have flaps. Let me tell you, you can possibly prove whatever you want to prove. But in our experience of over so many patients of chronic pancreatitis, it is my personal belief. So I'm going to do is, I'm going to place first 1 7-French stent. Now, potential question, why I'm putting 2 stents? Why not 1 10 French? I could have placed 1 10 French. But I'm putting 2 7-French stents because I'm very confident that there is a lot of muck still in the side branches, the dilated pancreatic duct. You have to understand that. and the side branches also. So we leave 2 7-French stents. The pancreatic juice will drain like a wick effect between the 2 stents. So even if the stent per se gets blocked, I am not worried, patient will not have symptoms. So this is the fundamental principle in leaving multiple stents. So there have been cases where I have put pilot endotherapy straight away 2 stents in the pancreatic duct, and patients have done fairly well. So do not hesitate. If there is a ductal dilatation, do not hesitate to put multiple stents on the right on the first go. This is my suggestion to all pancreatic endotherapy enthusiasts. So now I'm going into the tail, right up to the tail, and you can see the stent is right there. Pull out, please. Okay, so one stent is in place. Now, I will try and place one stent a little longer here, a little longer stent. The reason is to straighten the duct here. Otherwise, you'll create a stricture in the body and the tail junction. So I will tell you why we do all these things. Guys, you need to understand pancreatic endotherapy is a subject by itself. And you need to spend some time with people who have learned through their own lot of mistakes. We do know now that careful selection of technique will allow you predictable outcomes. And I'm going to now go and put a stent up to the tail area. Let us see. So this is another 7-French stent going into the pancreatic duct, ladies and gentlemen. Fluoro, please. Okay, this stent has come out a little bit. It doesn't matter. So another advantage is that when you put one more stent, both the stents are held together well, and the chance of migration becomes less. So all these things you have to spend some time and learn the tricks of pancreatic endotherapy. In 90% of patients, I will enter a pancreatic duct without a pancreatogram. Recurrent acute pancreatitis with negative EUS. Negative EUS in whose hands? That is important. Fluoro, please. Negative EUS is a very subjective matter. Let me tell you, EUS is a very subjective technique. So now I've gone up to the tail. Look at that. Out, please. So now you can see here that I've straightened the duct here on the fluoroscopy. So there is very little chance. Fluoro, please. I'm going to straighten the duct. I'm going to take out, because it's going in the side branch, so I'm going to take out the stent. Why do you want to use unnecessary technology like spyglass for laser pulverization of pancreatic stone? It's a fancy tool. Much better is ESWL, regular ESWL, and you break it. Yes, you can do a lot of things. Fluoro, please. Yes. Now I'm adjusting the stent. Fluoro, open. So I've adjusted the stent, and I think this is good enough for this patient. I think she will settle down. Now I want to tell you, this patient is going home this evening. I'm going to send this girl home with this treatment. This is our private practice protocols. She came with acute on chronic pancreatitis, and I know that this is going to solve her problem immediately because we have taken away the obstruction.